All right, it's all you.
Thanks, guys. Thanks for inviting us tonight to give this talk. We generally enjoy doing this, and I hope we have another good one for you guys tonight. Tonight, myself and Dr. Woods are going to be moderating. Somehow, Barrett got cut out of that. Sorry, Barrett. But the two of us will be moderating. We're going to introduce the topic today of high-grade Spondy. We really want to focus on high-grade as opposed to just, Spondy in general. And we have our four fellows with us tonight. We have Hesham Sala, Mark Lambrix, Mike Nolte, and Caleb Young, and they'll present some interesting cases to follow up on the talk. I just want to briefly introduce Barrett, one of my partners, and he's on the talk. Wants to say hi.
Yeah, obviously, I guess they picked the better looking of the two of us for the headshot introduction, but we're definitely very happy to be here. We kind of spoke briefly offline about content creation, and honestly, we can say I don't think anybody does it better than Seattle Science Foundation. Just the breadth and the dearth of what has been provided. I know even 7-8 years in practice, it's something I refer to, and so it's an honor to be here, and we're excited to kind of have an open and lively discussion about an interesting topic.
All right, thanks. So I'm just going to share my screen here. Give me 1 second. Okay, great. So like we said, tonight we're going to focus on high-grade Spondy. And I think it's important to just define what we're talking about. We should all be speaking the same language tonight. And so strictly speaking, a high-grade Spondy is a grade 3, 4, or a spondyloptosis by the Myerding classification. We're not really talking about slip angles. We're not talking about lumbosacral kyphosis. We're really going to focus on the Myerding grade. That's classically how it's described in the literature. Obviously, not obviously, these cases are usually isthmic. And so, the whole question of decompression, not decompression, is going to be in that light. There are some radiographic abnormalities which are, somewhat prototypical of a high-grade Spondy. So, most of us know generally these are high pelvic incidence type cases. There was an earlier classification, probably like 20 years ago, where they wanted to look at morphologic features of the sacrum and try to make a classification, but there's terrible intra observer reliability, so that was kind of thrown out. But generally, there's a dome sacrum, plus minus spina bifida, and then there are dysplastic L5 transverse processes, which we will see will become important based on certain types of surgical techniques. Understanding that there's a high PI and knowing that sacral slope and pelvic tilt combine ultimately to add up to our pelvic incidence. Some types will have high sacral slope, low pelvic tilts, and others will have relatively high pelvic tilts at low sacral slopes. But in any event, compared to normal controls, even in the setting of similarly high pelvic incidence type cases, these are even higher with even higher sacral slopes and pelvic tilts. In terms of a mechanistic etiology, while we know they're a high PI, it's not really clear whether the high PI itself is what leads to the high-grade Spondy, or whether there's just an association, not necessarily a causative one, between a high-grade Spondy and a pelvic incidence. Now, alternatively, in low-grade Spondies, there are two mechanisms that are classically described. There's usually the shear type, where these patients have relatively high sacral slopes and low PTs, and that shearing across the pars over time will cause elongation or microfractures, versus something like a nutcracker effect, where relative pelvic retroversion ends up kind of directing the force downwards onto the pars, almost cracking the pars, leading to Spondy in that setting. With an eye towards those two types of low-grade Spondies, Resco looked at 133 patients with high-grade Spondy, and in a cluster analysis was able to basically divide two cohorts of high-grade Spondies, what he referred to as a balanced pelvis versus an unbalanced pelvis. And that was compared to normative controls of people with high pelvic incidences in the absence of a Spondy. And so for the balanced pelvis, these are cases with high pelvic incidence, with a similarly high sacral slope and a relatively low pelvic tilt. That's the image on the left, as opposed to an unbalanced pelvis. Now, we're not talking about global alignment. Now we're speaking strictly about the pelvis. And here, these are retroverted pelvises with relatively low sacral slopes and relatively high PTs. And these will ultimately come in the later classification by Labelle and the Spinal Deformity Study Group. They took that a step further, and they classified 6 types of spondylolisthesis. Now, initially, they're graded as low grade versus high grade. Let's kind of skip over the low grade temporarily. It's really just low PI, normal PI, high PI. And then within high grade, there were really three types. There's the balanced pelvis. That's the same balanced pelvis as we had spoken about earlier by Resco's group. And then the unbalanced pelvis. So, and then within the unbalanced pelvis, are these patients globally balanced, which would be a type 5, or are they globally unbalanced? The purpose of this classification system was to better kind of direct the surgeon basically up to a potential type of surgery. So in the setting of a balanced pelvis, we're going to go into this in a little bit further detail shortly, but in the setting of a balanced pelvis, these may be patients who are amenable to, you know, the classic in-situ fusion, where we're not necessarily trying to change their morphology, we're just trying to lock them in place, versus someone who's unbalanced and globally malaligned, where if we don't fix them, we may set them up for failure later on. And just a quick picture to represent, this is from their actual paper. So on the left, that's a balanced pelvis. You can see normally, just looking, you know, from a bird's eye view, this does look like a globally aligned patient. Then we have what's called a retroverted or unbalanced patient, but globally balanced. I'm going to talk about this in a second, but globally balanced in the setting of a high-grade spondy is a little bit different than what we classically think of in terms of an adult spinal deformity. We're not necessarily looking at a C7 plumb line and trying to drop to the posterior superior aspect of the sacrum. We're really just seeing, do their head sit over their shoulder, right? So if you take like the T1, the centrum of the T1, does that drop over the center of the femoral heads? Because focally, you're almost always going to have some deformity because of the nature of that retroverted pelvis. So that's considered balanced. And then all the way to the right, that would be an unbalanced pelvis with an unbalanced spine. Obviously a positive SVA there. And the significance of this is that the deformity ultimately leads to dysfunctions. There are several studies that show that as you have increasing global malalignment, that will lead to poorer outcome scores, including the SRS-22. And Resco in his original paper did say that, you know, they were able to achieve upwards of 75% improvement in global alignment, almost normalization, with a formal reduction in instrumentation. I'm going to skip over most of the non-op. There's not a whole lot to do for non-op other maybe than hamstring stretching, things, some core PT. So let's talk about surgical options. And they really come in two flavors. There's in-situ versus a reduction in fusion, and then vertebrectomy, which I'll touch on shortly. And then for in-situ, there's either going to be anterior, posterior, posterior only. And then even among posterior only, there is with anterior column support, something like a Bowman, either let's call it a Bowman, or a sacral dome, or are we talking about in-situ? And we'll quickly go through all of those. So this is, you know, the literature, while it's sparse, meaning there's not necessarily what we would classically refer to as high quality literature, the follow-up is pretty remarkable. So these are 35 patients, consecutive patients with 30-year follow-up, which I think we would all agree is remarkable. And these were patients who were fixed with a high-grade spondy fixed in situ, something like you're seeing on the right side. And if you looked at outcome scores, they showed that at 30 years, they were largely equivalent to what would be expected for an age-matched control cohort. What I thought was even more interesting is they only referred to 3 patients with global sagittal malalignment, and that was defined as a T1 sacropelvic incidence. That's not necessarily something we use a ton. And if you look closer at their data, I think 7 of the patients had SVAs at 5 or greater. So like I said earlier, there in the high-grade spondy literature, there's been a bit of redefining what we're referring to as global malalignment. So assuming the head sits over the pelvis, which is largely what the T1 sacropelvic incidence is measuring, these were considered technically aligned. Now this is alternatively Molinari. So this was the WASH-U cohort. And so this was 32 patients comparing uninstrumented fusions in situ, instrumented posterolateral fusions, and then a reduction with instrumentation. That was a 360-degree fusion. And so understandably, the highest rates of fusion were seen in the 360 degrees, with a 45% pseudo rate in the uninstrumented posterolateral fusion. That, you know, you have to take one of these studies we're taking with a grain of salt, because this is the same cohort as the uninstrumented fusions with 30-year follow-up. And ultimately, no matter how they did it, there were no difference in functional outcomes. Of note, I had mentioned that in high-grade spondies, there are smaller TPs, and you have to be a little bit careful when you're doing a pure in-situ fusion to really get a good decortication at 5. And in the setting of TPs, which had a square radius, or basically a square area of a TP of 2 centimeters or less, you were more likely to pseudo. And that's not totally surprising. If you compare that with another cohort comparing posterolateral in-situ fusion anterior only or 360, here, while there were no differences in the Molinari study, here they did find improved ODI scores with a 360 fusion. So there was some differences in outcomes. Although if you look at larger series or even meta-analyses, generally we say that no matter how you do this, the outcome scores are all pretty much equivalent. The interesting theme here is if you look at lumbosacral kyphosis, so now we are looking at the slip angle, meaning the inferior aspect of L5, superior aspect of S1, without anterior column support, even in the setting of a fusion, that angle continues to progress. And it probably has something to do with remodeling and creeping substitution of the bone, given the high shear stresses across that joint or across that disc. They do continue to progress. If you use a 360, or if you use some sort of anterior buttress or column support, that can seem to be halted. So moving from pure in situ to the anterior column support that we were talking about, Bowman in 1982 described the technique of basically putting a fibular strut posteriorly, anteriorly, right within the axilla of that S1 nerve root, thecal sac and S2, and driving either a fibular strut, and now a lot of people are just using mesh cages directly across. There have been modifications of the technique. Hart described the modification of the technique where the screw itself serves as that buttress. So really long sacral screws going transsacrally, transvertebrally into the L5 vertebral body. Here, there were no cases of non-union if you're able to get that graft or cage in there with the screws. There were some cases of non-union without a graft alone, meaning if you just use the screw. Now, this is a pretty slick technique. It's certainly more technically demanding, but this is a sacral dome. So this was a small series by Boachi of 6 cases of a high-grade spondy undergoing partial reduction. So the thought here is that a full high-grade reduction may lead to increased risk of neurodeficit, which I'll speak about in a second. And the thought here was rather than try to improve the grade of spondy, you were just trying to take the angle, that high-grade angle where they're kind of almost in front of the vertebral body, and just bring it back to like a 3. In doing this, doing a sacral dome, there were no cases of neurologic deficits with a 100% fusion rate, admittedly a small cohort, but still an interesting technique. This I've never done, nor have I ever seen, but they describe an L5 vertebrectomy. I assume it's done more in the pediatric or adolescent cases, but basically it's an anterior vertebrectomy of L5, and then staged, they went to the back and removed the posterior elements. I imagine the reason this isn't done that commonly is because they reported a 23 out of 30 neurodeficit rate. Now, most of those were temporary. In fact, 21 of them were temporary, but 2 were permanent, which is a relatively high neurologic incidence. So moving on to whether we should reduce or not reduce. So the benefit of reduction is obvious. You will improve the slip angle, improve the Myerton grade, and ultimately likely improve both focal and global alignment. I think we have to ask, based on that Jolson series, is it possible that even if we don't reduce them the way we would an adult, classically adult spinal deformity, are we still achieving good enough reductions where their head is sitting comfortably over the pelvis, and at least at 30 years, this isn't leading to any long-term issues? I still think it's worth asking that series of 30, those are mostly patients done in adolescence. So you're talking about those patients are now about 40. You know, what happens to them when they're 60? And I think that's a fair question. It's not clear that a reduction necessarily leads to improved patient-reported outcomes. And certainly, I think most would agree that there may be a higher risk of neurologic injury. And so as far as neurologic injury goes, if you look overall at the literature, the rates I was getting was on average about 25 to 30%. Admittedly, most of those are temporary. That Molinari paper we had referenced earlier, they had 1 case of a permanent deficit, which added up to 4%, with 15% transient cases. So I think very conservatively, a full reduction, looking at a minimum of 15% transient neurologic injury, questionable about how many of those are permanent. And I think what's most interesting is there are at least 12 case reports that I came across of cases of cauda equina after an in-situ fusion. And that's probably later, maybe with that bone graft, they ultimately end up stenosing even worse. So it's not totally benign, even an in-situ fusion. And so this meta-analysis actually hit on that point. And while fusion with reduction certainly does decrease your slip angle and slip percentage, with an admittedly higher pseudo rate if you're doing In-Situ versus 360. All that is understandable. They did not find a statistical significant difference with neurologic deficits, whether it was an In-Situ or a reduction in fusion. So in conclusion, before we get to our cases, there are certainly numerous strategies for high-grade spondy, as we're going to see momentarily, all largely with equivalent outcomes. Maybe one paper shows superior outcomes for 360, but largely equivalent outcomes. Relatively high pseudo rates for an uninstrumented In-Situ fusion. I think most of us would agree that we've moved away from that. There's the suggestion that we may want to reduce, certainly the spinal deformity study group is suggesting reduction, at least partially, in grades 5 and 6, or types 5 and 6. And I think you have to be careful anytime you're doing a reduction that you really want a wide decompression. Now we're kind of tracing that L5 nerve root absolutely as far out laterally or anteriorly as we can go before reduction to try to mitigate that risk. Even so, there's not an insignificant risk of at least transient neuropraxia, if not full palsy. So thanks a lot. So let's move to some of our fellows. If there are any questions, feel free to leave them in the chat. Barrett or myself will, of course, kind of look at that chat and try to answer as many questions as we can. But if there are no questions now, I think Mike or Mark, who's going to take it?
I'll start.
Okay, perfect.
Let's see here. So everyone able to see this?
Yeah.
Yep.
I'm Mark Rex. I'm one of the fellows at Rothman. That was an excellent intro, Dr. Kaye. So first patient that we're going to talk about, she's a 69-year-old female. I believe, Dr. Woods, you can correct me, but I believe she came in the height of the COVID pandemic. She had progressive radicular leg pain, neurogenic claudication. She had actually progressed to the point where she basically couldn't really ambulate for any significant distances anymore. She'd gone through the entire non-operative management. Making the case a little bit trickier, she's a current smoker. And although I don't believe there was a DEXA scan on imaging, you can see that she definitely does not have optimized bone quality or ideal bone quality for screw purchase and fusion. So here are the AP and the lateral x-rays, and you can see that she has a high-grade spondylolisthesis. And as Dr. Kaye was saying, you can kind of make it out on the AP that transverse processes maybe aren't as ideal as you would maybe hope for. They really kind of look a little dysplastic throughout the entire lumbar region. So then we go to flexion and extension views. And again, you can see that she has a high-grade spondy. It looks like it might be a little bit mobile as well. And she has sacral kind of doming of her sacrum. So you go to the CT scan, as is consistent with most of these cases. Looks like my arrow got changed, but you can see that this is an isthmic spondylolisthesis. And those are most of your high-grade cases. You can see on MRI, she's starting to have pretty significant canal narrowing at L5 and S1. Pretty much the entire disc is gone at this point, and she's essentially almost bone on bone. Oh, sorry, giving everything away.
Hey, question. So why at 69 would you suddenly develop or gradually develop increasing ambulatory difficulty with, I'm assuming it's not like the slip changed in the last decade?
Yeah, I mean, you can, maybe it's not super obvious, but so it's both it's a combined kind of anterior posterior picture where maybe she had some ligament inflavum hypertrophy, maybe there was some more disc extrusion, maybe there was a little bit of progression of the slip. I mean, it's really hard to say, but clearly something changed where the canal narrowed.
Were her symptoms more one-sided or bilateral claudication?
So I can answer that, Scott. So this is a woman that I followed for about 6 months or so. In regards to her progression, what wasn't quite stated is she has a really terrible hip osteoarthritis on the right side. She has avascular necrosis, and that progressed. And I think that changed her gait, and that is one of the things that kind of facilitated her kind of progressive functional decline. So I think it's multifactorial. Her radicular symptoms certainly got worse. She had bilateral radicular symptoms worse on the side in which her hip was poor on the right. But it was multifactorial. She got COVID. She got deconditioned. She was poor protoplasm. And it happened over probably a 6 to 8 month time period. But she had been declining probably over 10 plus years, according to her son. But
Yeah,
she had bilateral symptoms. I think the compensation, though, honestly, was probably her hip. And if you go back,
so that's what I was going to ask.
go back to her hip. Go back to
Yeah.
her APX, or her hip is terrible.
Yeah, I noticed that, and that brings up the conversation that there's papers back 20, 30 years on hip spine syndrome, and which should you fix first, the hip or the spine?
So had she had unilateral symptoms, and it was pain with provocative internal external rotation of her hip, then certainly in a woman like this, probably I would have sent her for her hip first. But her symptoms weren't just consistent with organic hip pathology. She had true L5 radicular symptoms. She developed weakness in her hamstrings and EHL. It was bilateral, and it was progressive. And she got transient improvement with injections. I sent her to rheumatology. She got Prolia. She got on like a smoking cessation plan. And it was kind of really the transient improvement that she received with the transforaminal injection. Is what was kind of what pushed me over to say, we'll fix her back first.
Yeah, I mean, these are tough decision-making cases.
And if I can jump in, obviously the literature is still kind of being worked out between hip and spine first. But I think there's become relatively convincing and pretty clear evidence that if you are addressing the hip first, and then in any form, you change kind of any of the lumbar lordosis, you change the alignment at all, there's a very high kind of 3 to 5 times odds ratio where you're going to cause the patient to have a hip dislocation. So I think in the setting where you have bilateral radicular symptoms, I think that probably makes it a pretty easy decision to try and proceed with the spine first. So you can stabilize that, make it so that that's not going to change, and they can work on getting the proper alignment for the hip. But maybe other people have different opinions, but I think that's kind of what the literature is currently showing.
Well, this is Izzy Lieberman. There's certain things that you can pre-plan. And this is where you have to, along with the hip colleagues, decide what are you going to do for this lady. If you're going to fix her back, the likelihood is you're not going to change that lordosis or her pelvic incidence that much. So the hip can certainly be done first, knowing that, and then see what happens to her. The concern that I'd have with this case is if you operate on her back with a hip like that, she's going to have a very tough time rehabbing from any spinal surgery. She's going to have a tough time walking, moving, getting around. So there's a lot of things, but pre-op planning it, you probably could get away with doing her hip first and then seeing what her back is like, and then addressing the radicular symptoms of her spine.
Thank you, Izzy. This is Jan. So the one other concern I have is this is not just a routine hip arthropathy. This almost looks like a neuropathic hip to me. So I'd really want to look at her cord. And again, I don't see the patient, but carefully look for myelopathy. But I'm fully in concert that after making sure she does not have myelopathy, I'd probably fix that hip first. This is not weight bearing. She can't mobilize after spine surgery. The interesting thing is 2 other things. First of all, I'd make a strong plea based on a CT scan for bone density measurements of the non-spine area, not of the right hip, obviously, because that looked pretty impaired, and that might influence what I want to do. And in terms of this spinal stenosis, this is a super interesting case because she has a true corniform sacrum. I mean, the sacrum is truly 90 degrees bent. This is a decompensated. That's a great introductory lecture, by the way. Spondy. And basically her L4 lamina is now sitting on S1 as she's standing. So she has a truly decompensated lumbosacral junction where L4 is now creating a central canal stenosis. So She probably needs a 1-2 punch pre-rapid. I'd still plead for a hip, and I'd put on my hip colleagues to give her an extra large cup or something to not let that dislodge. But again, I stay with all the previous things. Look for myelopathy and to check bone density. Thanks.
You know, it's also interesting is that she's gone 69 years with such a hyperlordotic lower lumbar spine, and her 4, 5, and 3, 4 discs are still pretty good looking, at least height wise. So throw some of our mechanics right out the window.
So Mark, I saw you spilled the beans a little bit there, but what do people think? You know, Barrett, this is definitely a case that needed a decompression. She has radiculopathy, claudication. These can become challenging in cases of In-Situ, especially all posterior, to get a fusion, even with iliac crest, especially in the setting of a decompression. This case, any case, what do most people think about a decompression in the setting of an all posterior case, even something like a Bowman there where you certainly need a decompression, versus leaving the lamina on to try to get that bony fusion?
I suspect you're going to have a very tough time doing a decompression, leaving the lamina and leaving those facet joints or the remnants of the pars and the facet joints in place. If you want to do a good decompression, you're going to have to take it all down.
So I think that Dr. Lieberman, Dr. Chapman made some really excellent points. And, you know, obviously very, very challenging case. This is a woman I followed for a while. And certainly she was somebody that I considered having her hip fixed first. The problem is that her symptoms were truly bilateral and progressive, and she started to develop weakness, particularly in her hamstrings and her EHL. And so, you know, when I was evaluating the case, the question is, okay, she's a smoker. We stopped smoking. We put her on Prolia. She doesn't have great bone quality. I questioned my ability to get a reduction on her. The concern I had with reduction was not so much a neurological deficit. Obviously, that's a concern. But, you know, the biggest concern I had was screws pulling out of her back at L4 and L5. And then what situation am I in at that stage? She's 69 years old. She's lived like this for quite some time. She has a terrible hip. The question is, okay, you know, what is the low hanging fruit here? What is this woman's ceiling? What is her floor? And I thought that the floor would be much lower if I attempted some reduction and I pulled out my fixation. So what I ultimately contemplated was an In-Situ fusion of reverse Bowman's versus just placing fixation in her. You know, if I could get good fixation at L5, I didn't think I would do a Bowman's procedure, understanding certainly there's a high risk for pseudoarthrosis, wide decompression and gill laminectomy to kind of skeletonize her nerve roots at L5, and then kind of see what was left. Obviously, I was thinking about pelvic fixation as well. And so ultimately, what made the decision for me was she had kind of a low bifurcation, and that wasn't imaged, but her bifurcation was low. She had pretty substantial sclerosis of her end plate. So if you think about her best bone, some type of transsacral fixation probably would have been good. But my concern was pushing out anteriorly and getting a vascular injury. Had her bifurcation not been so low, then I would have done that. But ultimately, I thought I could get good screws in L5 and L4, and then put some iliac fixation in as well. And then, you know, see what we got. This is a woman where, you know, I felt like a single was better than a home run, considering all of the, you know, the other factors that she had. You know, that's how I addressed it.
I think that's a great point, Barrett. Meaning when we're talking about earlier for trying to get global realignment, I forgot, maybe Jens or Izzy, somebody had mentioned that, you know, she lived 69 years like this. So probably trying to get a home run full realignment, probably you're right. You know, you don't want to be necessarily sorry and, you know, crying on the way out of the operating room when all the screws rip out by trying to over reduce her.
Well, so I considered doing a sacral dome osteotomy. I considered doing kind of a hard or a modified Bowman's, all those things that were certainly within play. I think the thought process that probably her most sclerotic bone was her end plate. So I did certainly consider some transsacral fixation, but what dissuaded me from that was, you know, her vasculature and kind of her bifurcation being right in front of the kind of the tip of that L5 vertebral body. And obviously, if I pushed forward anteriorly, then that's a catastrophic outcome. And so it was really just trying to mitigate complication, just kind of accepting a single, doing a wide foraminotomy decompression on her, decompressing her L5 nerve roots and kind of stabilizing her. And and that's what I did. So show the post-op pictures, Mark. So I put screws in L4. I did Wilsey incisions. I put screws in L4, L5, and S1, and then I got an iliac bolt and got reasonably good purchase. I put 7.5 millimeter screws in a woman. This woman's only 5 foot, less than 100 pounds. So those are pretty big screws. I was pretty happy with the fixation. I did very, very wide decompression, skeletonized her nerve root out of her spine. And I agree with the critiques that Dr. Chapman had about her ability to weight bear on her hip. When she came in, I saw her on my schedule post-op, and I looked at my staff, and I didn't know how it was going to be. And she had her walker, and she was bouncing on her legs. She was smiling. It was pretty remarkable, how well she was doing in the acute post-operative period. Clearly, I think, and I told her she's going to have to get that hip fixed probably to optimize her because she has a substantial leg length discrepancy. But we were able to address her neurological symptoms bilaterally. Her L5 radic symptoms improved. Her weakness did improve, and she's walking with a walker. And so I think in a woman like this, I think this is a reasonable outcome. I think this approach could certainly be critiqued, and that's why I presented it. But my concern was trying to reduce her could have resulted in a much more, a much worse situation. So I'm interested to hear the more senior, surgeons, thoughts on this.
What biologic did you use for her fusion?
I very rarely use BMP, but in this woman, I use BMP. I mean, she's a smoker. She, her TPs were, we don't have the CT scan. She didn't have great TPs, but she did have TPs at L4, L5 in her sacral ala. And so I did use BMP for her.
Well, the clinical results speaks for itself.
Yeah, she bounced into your clinic.
Yeah,
we can't argue with that.
I mean, decompression and stabilization, and a good result, that's a home run.
All right, that's a nice case. Mike, you want to present yours?
Yeah, absolutely. Give me just a minute here. Hi, everybody. I'm Mike. I'm one of the fellows as well. Thanks to Dr. Woods and Dr. Kaye for the introduction. This is a patient of Dr. Kaye and Dr. Kepler's from a few years back. This is a 41-year-old female. She's had 20 years of progressive low back pain as her chief concern, but she also has pain radiating to her bilateral posterior buttock and thighs, otherwise reasonably healthy and active. On exam, she has a BMI of 33.4. She has limited extension at the lumbar spine, so secondary to pain, but otherwise a largely unremarkable exam without red flags or worrisome findings. These are her initial plain films at the time of exam. Ignore the disc height measurements at the 3-4 segment there that I couldn't get rid of, but you could see the L5S1 grade 3 isthmic spondylolisthesis with some sacral dysmorphism, no significant scoliosis on the AP film there. On flexion extension, maybe a slight degree of mobility, maybe slightly more than our previous patient. I wouldn't call this an adolescent at the age of 41, but slightly younger than our previous patient, and probably with a little bit better bone quality, especially in the absence of smoking and in the absence of significant medical concerns. This is select sagittal cuts of her MRI, redemonstrating her isthmic spondylolisthesis, and then severe, probably left worse than right, foraminal stenosis secondary to both the pars defect and the listhesis itself. And then a sagittal cut of the CT scan showing a little bit better view of that sacral dysmorphism, some of that sclerosis at the L5S1 articulation. I would say in general, this is probably a little bit more of a balanced pelvis, as Dr. Kaye was alluding to in his initial presentation, as compared to our last patient with a little bit higher of a pelvic incidence. And I think that's something that should enter our algorithm for how to best treat this patient. No significant central stenosis, looking at L4-5 and L5-S1. Really the foraminal stenosis more so the issue from a neurological standpoint. So with that, I'll ask the panel if they have any specific thoughts, concerns, questions when approaching this patient.
Yeah, so I think this is a patient that clearly has to be addressed maybe a little bit differently, right? She has no central stenosis. This is not a claudication case. This is purely a radiculopathy case, which means she needs a decompression. And so if we know we're going to be taking down a lot of those posterior elements to do as good of a decompression as possible, I think here talking about, is this, an all posterior type of, reduction decompression with some sort of inner body versus, something else. But I think In-Situ doesn't work for a case like this, where the issue is primarily a radiculopathy. And I personally am always a little bit worried with these, kind of wide decompressions, trying to do an In-Situ and losing my potential fusion bed in an already challenging fusion environment.
Would anybody consider this for that Bowman fibular, albeit In-Situ, but doing a posterior decompression, but getting the inner body with the Bowman fibula technique, or whatever fixation you want to use, cage or fibula?
Yeah, so this is a very big woman. She was a very large woman, and in retrospect, I don't know, maybe we would have done it differently. But I don't know, Mike, you want to show the post-op? So this is actually somebody who we thought that was an excellent option for.
Has anyone? I may have missed it, but did you flash up a full-length head-to-toe X-ray on her to look at her overall balance?
Unfortunately, we don't have one. It was in a outside system that we didn't have access to, but per the report, she was reasonably well sagittally balanced from a global standpoint.
Yeah, and I think that's something that you have to take into consideration when you're looking at potentially reducing or fusing In-Situ and looking at the slip angle and all the other things. In someone this robust, you can dig yourself a giant hole that you can't get out of, or you can do something a little less difficult and hold her in place if her sagittal balance is right on, and decompress those nerve roots and still get a really good result.
Great, all excellent points. To Dr. Blumenthal's point, we did do a same day 2-part procedure, going anterior first, then posterior. First localizing that, you can see on the left that L4-5 disc space, and putting a K wire across the L5-S1 interface. Over that K wire, putting a few ACL reamers to the point that we could place a 11 millimeter fibular dowel graft with kind of this reverse Bowman technique, if you will, with Bowman initially describing it from a posterior perspective, but then with this modified technique, also doing a L4-5 ALIF. So you can see the femoral ring allograft of the L4-5 interspace, which I think certainly improves your L4-1 lordosis, but also your L1-S1 lordosis, and probably some of your global sagittal alignment as well. Flipping the patient posteriorly, performing your gill laminectomy at the L5-S1 segment, and then instrumenting L4, S1, and then S2 Ayler screws into the pelvis. We thought this was a nice option for this patient, and she's doing well at a couple years post-operatively. These are just some sequential imaging looking at her preoperative, where she stood. This is the lateral after the first part of the procedure. Tough to visualize that fibular graft, but it is there, and you can see the femoral ring allograft at the 4-5 segment, and then the posterior instrumentation acting as a buttress to hold her in place and helping improve some of that sagittal alignment for her. And like I said, she's doing well and is happy.
So a couple of critiques of our own work. So subsequent to this was done maybe 5 or 6 years ago. And we've seen among all the guys at Roth, and we've done a number of these, and we've had quite a few fibular fractures actually. So we have largely moved to like a mesh type cage. We size it and then pack it either with BMP or autograft, iliac crest. and obviously less fractures that way. The other thing is people who still use it where they dip the fibular graft. I know Dr. Kepler's doing this a lot. He'll dip the fibular graft in like gastrographing, that then he can actually see exactly where it is, because you sometimes lose it and you're not really sure, you know, and especially in a big patient like this. By the way, to Dr. Lieberman's point, we like to make these larger patients our general surgeon colleagues' problem, not our problem. So we didn't want to dig ourselves into a problem. Let them deal with it.
Touche.
But really, to the point is, I think not every patient needs a full reduction, especially if they're globally aligned. I'm sorry that we don't have the full length here. We have multiple PAC systems. But in the setting of a well-aligned patient, these are certainly less technically demanding cases. If you don't need a full reduction, certainly less risk to the patient and usually a nice outcome.
Thanks.
Nice job. There was a manufacturer used to make like a double long tapered cylindrical cage that you could use the same way, you know, pack it with graft and even tap it and screw it over a K-wire. But I don't know if they still make it, but it was very
so
good for this application.
So Jack, back earlier in my career, I did a couple of these, and it was whatever the company that owned the BAK cages, the company from Minneapolis, they would do custom, they would do custom BAK cage for exactly that anterior Bowman type approach.
Yeah, but that's a great job. You got good fixation and you get good cortical fixation on the end plates as you go across L5S1. And you're right about getting the approach through the L4-5 disc. That's really the best way to do it. So very nicely done.
Jens, I think you're muted.
I think it just kind of speaks, that case is crazy because it kind of speaks to how many different ways these things can be addressed, right? I mean, you could definitely have done that all posterior, but certainly the benefit of doing it anteriorly in a big patient in which you can put a large graft at L4-5 and really maximize lordosis, particularly considering that you are fusing that patient In-Situ. You know, it just kind of shows the dealer's choice kind of nature as long as the principles are adhered to.
Caleb, you want to show the next one? We'll change it up a little bit.
Yeah, absolutely. Let me just share my screen here.
Hey, Dave, I don't know that background, but you look like you got a mohawk. You might want to change. You might want to change that background.
What do you mean? What's the problem with that?
You all able to see my screen here?
Yeah.
Yes.
Yes.
Okay, great. Excellent. So I'm Caleb Young, one of the fellows at Rothman. This is another case presentation. So this is a 49-year-old female who had low back and right greater than left lower extremity radicular pain paresthesias for several months. It worsened after a slip and fall. She had tried physical therapy, physiatry, and NSAIDs with only modest relief. Difficulty with stairs and ambulation in particular. Past medical history, fairly unremarkable. Anxiety and depression well controlled. She's a non-smoker, works as a teacher. Her BMI was 24.8. On examination, she had thoracic lumbar flexion about 70 degrees, extension of 5 degrees, and pain was pretty significantly exacerbated with flexion. Had some weakness with her right EHL and tibant, otherwise 5 out of 5. Intact sensation, and rest of the exam fairly unremarkable. Here were her preoperative x-rays. So again, just demonstrating, I think more well appreciated on the flexion extension films, a grade 3 spondylolisthesis that reduced to grade 2 in extension. We did not have a CT, but her MRI here, it was clear that she had a Isthmic spondylolisthesis at L5S1, just kind of going through the cuts here. Really no significant central stenosis, but had foraminal stenosis bilaterally right, a little bit worse than left at that level. Just going through kind of on the right panel now, the paramedian sagittal T1 cuts there. So I'll just kind of turn it over to the group just for some discussion on thoughts about how to approach this case.
So from we'll let this deformity guys talk, but from a degenerative surgeon point of view, if she reduces to a grade 2 in extension and you can get her to a grade 2 on the table, you may be able to do an anterior posterior, put a cage in anteriorly, perk screws in the back, and have indirect decompression of the foramen. It all depends on that sacral slope, because obviously if the pubis is in the way of doing an anterior discectomy and putting in a parallel, a cage that's parallel to the disc space, it becomes a technical issue. But if it's reduced to a grade 2 on the table and extension, you might just be able to do, what we would call a mini 360, ALIF with perk screws, indirect decompression, and boom, you're done.
Yeah, Scott, to your point, these are like juicy cases, I think, when most of us see these, because, that does look quite significant inflection, but I think most of us would agree, that patient walks in like that without inflection, that's a relatively regular day in the office. And in our own group, we looked at our patients, TLIF, ALIF, perk screws, and which ones did the best. Ultimately, in our cohorts, the ALIF perk screws did outperform the others, both in terms of fusion and patient-reported outcomes. So that is a really nice option. I think you can make an argument, even something like an MIS TLIF or, a single level. And then because the question is, what do people think about single level here at 5-1 versus trying to get that extra fixation at 4-1, either anteriorly or posteriorly, or is that not even an option that you guys are thinking about?
Yeah, Scott said if you can reduce it to a grade 2, and sometimes even just doing the discectomy with a little intradiscal distraction, it'll reduce, to like a grade 1 or even back to neutral. Then there's no need to have to get fixation above. And even if it's hooding the anterior part of the disc space a little bit, you always have the option to osteotomize the anterior inferior lip of L5 to get you a little bit better visualization into the disc space. And, there's no foul on that since you're doing an arthrodesis anyway. So, I think this is a blue plate special for most of us with a predictably good result.
And probably you could stop at L5 considering there's not substantial dysplastic features in this patient, right? So likely this patient is going to have reasonably good transverse processes and reasonably good pedicles at L5. And so probably, you would not have to go to L4 in a patient like this in the absence of any substantial dysplasia.
Okay, what do we got?
Yeah, absolutely. So kind of as we discussed, definitely taking advantage of the fact that she would reduce to a grade 2 kind of in extension or supine. So these are the intraoperative x-rays. So she had a ALIF done at L5.
Can you please reshare your slides? I'm sorry. Can you please reshare your screen?
Okay. You guys able to see this then?
Thank you.
Okay. All right, great. I don't know why to stop sharing, but yeah, so kind of as we discussed, we definitely took advantage of the fact that she had reduced or was able to be reduced to a grade 2, just kind of being in supine, positioning on the table. These are the intraoperative x-rays here. So this is the x-rays from the procedure showing that ALIF done at L5S1. This was, I think, like a 14-degree lordotic cage. And then she had backup with the posterior percutaneous screw fixation L5S1. So 2-week post-op x-rays are shown here. And then we tracked her out to a year post-op. So here are her standing films, and then more importantly, her extension and flexion films. And she had resolution of her weakness. She had full 5 out of 5 strength, and then resolution of her pain.
And from a rehab standpoint, they rehab, as you know, very nicely and very quickly.
Yeah, so actually, so this was my case, and I totally agree. These are like super predictable, like these patients do great. I will say this woman, and maybe it was her psych history, really for like 6 months, really was complaining of like a bilateral radic, which I do see not that infrequently when I kind of stretch them out and reduce them. I wonder if you guys are seeing that, and if anyone has any tips or tricks. I mean, I can tell you what I do when I see this, but it's usually, Lyrica, kind of reassurance, gabapentin, those types of things for these maybe stretch.
So we actually looked at our ADRs that we distract this much, if not more. And we had a 9% incidence of postoperative radiculitis. And sometimes you can convince yourself that you've left a little bone spur in the foramen and you go back and do a decompression. And it turned out that the medical management, as you discussed, worked like 2/3 to 3/4 of the time in, usually, 6 to 12 weeks. And we had the patients that we actually went back in and did foraminotomies didn't make a difference. So exactly what you're saying is kind of what happens is 2/3 of the patients are going to get better with medical management. And we think it's just, I don't know what you think. We think it's kind of a stretch neuropraxia, although we went back and looked at our intraoperative monitoring and none of them had intraoperative monitoring changes. So I don't know that the intraoperative monitoring is helpful at all.
So here, this is such a great group. This is Jens. I would suggest we look at the postoperative CT scans in these patients, because what I've seen is, especially for spondies, they can develop this little shelf on the inferior L5 body that juts out posteriorly, that in its normal dislodged state cradles the L5 root. When they distract them and kind of push the L5 body back, like what's beautifully done here, this can suddenly then serve like a fulcrum that pulls into the nerve, because the nerve will pull down or wants to go down towards the ala. So let's look at these patients with postoperative CT scans who have these new radiculopathies after they've done a distraction maneuver, because that, in my practice, I've been totally there. I'm so glad you mentioned this. Thank you, David. I've had the same thing. It's been very frustrating. Beautiful surgery, and then when I look back, there's this little edge, and I've actually taken 2 or 3 patients back. So very frustrating, great observations, but that's my best theory.
Yeah, it's super frustrating when they have pain. It's even more frustrating. I've had 2 patients who had foot drops, and I actually monitor them now. I do every case where I do a case like this, I use motors because I'm worried. And I had a case this past Friday, same exact thing. Everything's going great. I'm high-fiving, everything's great. They run a final motor. The tib-band is at 4%. I was like, oh my God, like I can't believe this. And there's nothing to do at that point. I know I'm just going to go in the back and decompress them. I took it out, I let it drop, whatever. 5 minutes later, 100%. I can't explain that at all. The guy woke up totally fine. But I've had 2 patients now who have had foot drops after this exact case. I got CAT scans on both. To Dr. Chapman's point, both of them had a shelf. I decompressed them both. Neither of them improved. They improved with time over about 3 months. They both, thank God, recovered over about 3 months, but neither improved immediately after decompressing that little shelf at L5, kind of taking it down, looking at that nerve.
So let me just add one thing to Jens's and your comments on that. If you think of this anatomically, that shelf that you see there is exactly where the dorsal root ganglion originates. And when you do the reduction, the excursion of that L5 nerve, you're sliding it back and you're probably pulling it into that shelf. So I think it's the dorsal root ganglion that's getting impinged upon as you're doing the reduction, as the nerve is following the excursion of your reduction in there. So it is an important thing to take that down if you can reach it. And this is an area where I really like the ultrasonic bone scalpels and bone hooks that we have now to just melt that piece away, so you don't have something whirring a high-speed burr in there to try to melt that osteophyte down.
Well, dorsal root ganglion irritation would explain the sensory disturbance, but not the motor dysfunction.
I think there's the stretch to it as well. Okay, so the pain, the stretch, and you're just sort of pulling it right into that little tunnel there. Think of a Chinese finger trap is what you're doing with that L5 nerve root.
Dr. Blumenthal, it'll be fascinating to see your series of patients that you went back and decompressed, if they actually had that shelf or not, and if that's something that can be formally described. We've all seen it, but I've not necessarily seen that formally described in the literature. And to see if there's a correlation with the patients that have that shelf versus those that don't, and if there's some type of, if the patients that do have it respond to foraminotomy. It doesn't seem like in Dave's circumstances that they did acutely, but ultimately, thankfully, they did improve.
Yeah, and we kind of agree with David, is that it didn't seem like the foraminotomy did anything, but with time and medical management, they seem to get better, mostly. Not everybody.
We have time for one more. Let's try to rip through it. Hesh, you want to try to get through this?
You got it. Everybody sees my slides?
Yep, go for it.
All right, so I'm Hesh. I'm the last spine surgery fellow here at Rathman. So this is going to be a case that Dr. Kaye actually did when he was a fellow here. So it's a 25-year-old female who actually came to us with a chronic lower back pain. She had pain that radiated to her bilateral lower legs, mainly along her lateral thighs, calves, and then the dorsum of her feet. No bowel or bladder issues, and she had no red flag symptoms. She failed physical therapy, and she has taken NSAIDs in the past, which have not really helped much. She is neurointact with the exception of 4 to 5 big toe bilaterally, a decreased sensation along the L5 distributions bilaterally, and she had no upper motor neuron signs. So imaging here, similar to previous cases. So she had a high-grade spondylolisthesis that we could best see here on the lateral. Unfortunately, I don't have the flexion or the extension views here. Then the MRI, so the most notable thing is bilateral L5 foramen are both pretty tight on both sides. So that's her biggest thing right now. And then the next slide is going to be surgery. So I think I'll pause here for a second.
You know what, maybe just show the post-ops and we can talk about it just for time.
You got it. So we ended up doing a sacral dorm osteotomy. So these are her post-op images. So initially, screws were placed at L4 through S1 and then the pelvis. And then it was partially reduced, and then an interbody was placed at 5-1. And these are her post-op images here.
So that's nice. I think the important thing here is, you know, it is possible in a young patient to get a reduction. This patient did not have a neurologic deficit, but that obviously is our biggest concern in the case of a high reduction. This is partially reduced. We'll call it, you know, grade 2, 3-ish, and that's totally fine. You know, you get out of Dodge, you're happy. Her alignment, I think, is certainly acceptable. This woman had a nice outcome.
Yep.
And say it's a young female, do you try and always avoid going anteriorly, or what are your thoughts on that?
So personally, you know, young female, young male, young patients in general, it's a concern. I have to say I've moved away from it being a major concern, even in young men. I don't have that much of an issue with it. We have pretty excellent vascular surgeons. We don't use a hot knife down there. Thankfully, we haven't seen any sort of retrograde or any, you know, sort of sexual dysfunction. I know Chris Kepler is doing a study now looking at sexual dysfunction in these patients. We haven't seen it be an issue yet. I know it's a risk. We certainly counsel all our patients appropriately, but I think you can really get such a nice outcome sometimes that I don't want to not give them that benefit. I don't know how other people feel.
I mean, there are a couple of large case series, and the incidence seems to be about 2%, with half of them resolving spontaneously within a year. So it's really a small number. The older literature of transperitoneal 30 and 40% of retrograde is just, you know, inappropriate these days with a nice retroperitoneal approach.
Yeah, and recently I had a female patient ask about it, so I did a little research on it, and we don't seem to see sexual dysfunction in females. So females, we don't even think twice about it. Males, obviously, you know, like Jack said, 1 or 2% incidence of retrograde.
Really nice case. That looks great. So I think we're about ready to wrap it up. We're pushing up on 9 o'clock. These were great cases, guys. Thanks for sharing. Again, Seattle Science, all the experts on the panel. We appreciate all of you. All great insight, fun cases. So it's always fun. We always like being here. If there are no other questions, I think we're going to wrap it up. I don't see anything in the chat. We'll give a couple minutes. And then if there's nothing else, we'll say goodnight.
Hey, we really appreciate it. Thank you, Rothman guys. You did good.
Hey, Jack.
Yeah.
Can Linda, Angela, you and Jens stay on about the motion thing that we're running into?
You bet. You
Okay.
bet.
Sure. All right, everybody.
Good job. Good night, everyone.
Thanks,
Sorry,
guys.
the CME slide is coming up. Hang tight, folks. It's just thinking very slowly. I did put the CME information in the chat box too. The code is 851.
That's right, Linda. 851.
851.
Yeah, I got it.
Great.
Good night, guys.
PowerPoint.
Good night. Good night, everyone.
Night.
Hey, Dr. Blumenthal, I can chat for a minute, but I do have an HOA board meeting at 6 o'clock that I'm slipping off
No,
to.
this really quick. Jack talked to me about. I'm gonna get in touch with Matt Scott Young and our morning, his evening.
Right.
If
Hey,
he's
by
got
the way,
issues.
Dr. Blumenthal, just so
Yeah?
you know, there's 32 people still here.
Oh,
Okay.
let's,
So do you want to do a quick phone call? I'll just call you real
I'll-
quick.
I
Yeah,
think
call
it's
me
o-
and I can tell you what Jack and I
Yeah.
talked about.
Yeah,
Okay,
we just have
sounds good.
a plan B, Linda, that's all.
Perfect.
yeah.
Great.
Yeah, all right, I'll talk to you in a second.
Okay, sounds good. Okay, sorry
care,
everybody
guys.
about the CME slide. Good to see you.
Bye,
Oh,
Linda,
there we
thanks.
go.
Bye.
Bye, Jens.
You bet. Okay, here we go. Share screen.